Now I call Dr. Parul to present her talk on role of MRI in aortic and carotid plaque assessment.
At the outset, I would like to thank the dignitaries of Asia Pacific Vascular Intervention Society for having given me this opportunity. So these are the questions that we are going to address today in this next 10 to 12 minutes. So what are the characteristics of vulnerable plaque? We all are aware of the process of atherosclerosis, which begins with deposition of lipid as an early atheroma in the intimal layer of the vessel, which, if uncontrolled, incites an inflammatory reaction and leads to formation of what is known as the vulnerable plaque, which has a large lipid pool, a thin fibrous cap, and lot of inflammatory cells around it. This is typically what we label as the vulnerable plaque. If it remains uncontrolled, there can be rupture of the thin fibrous cap, which can lead to an embolic phenomenon. So, having said this, this is what we look at when we are looking at vulnerable plaques. So, we look at presence of intraplaque hemorrhage, lipid-rich necrotic core, thin fibrous cap, enhancing vessel wall around the plaque, and surface conditions of the plaque, whether or not we are able to see ulcerations over the plaque. Now, going on to the next question, that why and how does MR imaging aids in detection of these plaques? Now, why MRI? MRI because it has an inherent high soft tissue contrast. The lumen as well as the wall of the vessel can be imaged in a single study, that too non-invasively. High resolution imaging is possible using surface coils and sub-millimeter acquisition, and of course there is lack of ionizing radiation. So over last 2 decades, there have been several studies which have looked into the role of MRI for detecting these vulnerable plaques and finding the risk assessments for stroke using this technique. This is a systematic review or a meta-analysis which was published way back in 2013 in the Journal of Stroke, which said that presence of intraplaque hemorrhage, lipid-rich necrotic core, and thinning and rupture of the fibrous cap on MRI of carotid plaque is associated with increased risk of future stroke or TIA. And this, they have further asserted, is the stroke risk information that MRI gives is beyond what luminal stenosis is there at that point in the vessel. So having said this, how do we incorporate vessel wall imaging in our routine protocol? Routinely, what we can do is in patients where we are imaging patients with stroke, we can just add 2 techniques, simple techniques, that is fat suppressed Stephen weighted black blood imaging and a post gadolinium fat suppressed Stephen weighted black blood imaging for evaluation of these plaques. Now, why Stephen weighted image? A Stephen weighted image is because the blood degradation products in the early and late subacute stage cause Stephen shortening. Hence, they look bright on Stephen weighted sequence. Why black blood? Why black blood is, it's a flow suppressing sequence. So the lumen becomes black, and fat suppressed is that the fat around the wall gets suppressed. So the wall of the vessel is much better appreciated using this sequence. Why do we need to use contrast? Because we want to look at inflammation and we want to differentiate the necrotic lipid core, which will not enhance, as against the fibrous cap, which would enhance. So this is an example of an intraplaque hemorrhage. By the rule of thumb, most of the time, whenever you see a bright signal on Stephen weighted sequence within the plaque, one has to think of intraplaque hemorrhage. So here, this is the vessel lumen and this is the plaque, which is showing a bright signal on T1. It is hypo on T2 and not really enhancing on the contrast enhanced Stephen scan. This is typical example of an intraplaque hemorrhage. Yet another example, here we have the sternocleidomastoid muscle. So normally we compare the signal intensity of the plaque with the sternocleidomastoid muscle. And if it is bright, we know that it is bright on T1. And again, by the rule of thumb, we would think of intraplaque hemorrhage. This is an example of a lipid-rich necrotic core. So lipid-rich core actually would be slightly bright on T2, but would be iso to slightly hypointense on T1. But what would be diagnostic would be on the contrast enhanced scan, the lipid core would not enhance. However, the fibrous cap would be seen enhancing. So this is typical example of a lipid-rich plaque. Now, how do you identify the fibrous cap on MRI? A thick fibrous cap would be seen as a dark band between the white lumen and the gray wall, whereas a thin fibrous cap would not be seen at all. If there is a cap rupture, we would see a bright gray region near the lumen with or without irregular surface of the plaque. So let's see an example of a thick fibrous cap. So you're seeing a dark band, that's the lumen, this is the plaque, this is a thick fibrous cap. As against that, there is absence of that band here, which indicates that it's a thin fibrous cap. To look for rupture, you look at loss of signal, loss of the dark signal in the dark band, and it is replaced by a hyperintense signal. So you know that this is the site of rupture from the plaque. Now, having said this, let's look at the modified American Heart Association classification for these plaques based on the MRI findings. So they are classically divided into type 1 to 2, which is almost near normal, type 3, which indicates diffuse intimal thickening or a small eccentric plaque, type 4-5, wherein there is presence of lipid or necrotic core within the plaque surrounded by fibrous tissue. Type 6 is a complex plaque, which would have hemorrhage, would have surface defect or thrombus within it. And type 7 is a calcified plaque, whereas type 8 would indicate a fibrous plaque. So let's try and look at the examples of each of them. This is a normal vessel wall. You see normal uniform wall thickness. So this is example of type 1 to 2. This is a typical example of a type 3 plaque, wherein you're seeing eccentric wall thickening with some signal changes within. In this case, as you see, there is no even bright signal within the plaque, and this is a typical example of a necrotic core and a type 4-5 plaque. Next is a complex plaque which is bright and even again, so intraplaque hemorrhage, there is thinning of the cap and probably some ulceration, so this is a complex ulcerated type 6 plaque. And lastly, we have a plaque which is hypointense on all the sequences, and it is the calcified plaque. Now, going on to our next question, what is the clinical impact of this technique? Why do we need vessel wall imaging? In patients who have been labeled as cryptogenic stroke, where no cause has been found, there have been several studies that have been done to look at the carotid bifurcation particularly, and to detect the culprit lesion. And it has been really very promising. I will show you in the next slide. Then in patients who are at high risk of stroke, selecting the patient for carotid revascularization versus medical therapy, again, is a question which can be solved by using vessel wall imaging and looking at the plaque burden and the presence of vulnerable plaques in those set of plaques. Next, decision between carotid and arterectomy and carotid stenting is again based on the presence of a rupture-prone plaque, which has a tendency to dislodge while going in for a carotid stenting. So again, whether a carotid stent should be done or whether the patient should undergo a surgery or maybe other methods like flow diverters or covered stent should be used is based on this imaging. Lastly, to monitor treatment response, yes, MRI is definitely promising to look at the total plaque burden, the plaque volume, as well as the characteristics of the plaques, whether or not the therapy has changed them. So this is the clinical utility of MR imaging. Now, this is a very interesting article which was published in 2012, wherein they had studied the patients with cryptogenic stroke, and they had studied the prevalence of non-stenosing complicated atherosclerotic plaques using MRI. And it was found that arterioarterial embolism from complicated non-stenotic carotid plaques may play an important role in a subgroup of patients which were previously diagnosed with cryptogenic stroke. So here we are trying to assess the culprit lesion using MRI. Now, last segment is the role of MR in aortic wall imaging. So traditionally, actually, transesophageal ultrasound has been used very, very commonly to look for mobile plaques in the patients who are suspected of having stroke due to embolization from the aortic plaques. Now, I would like to share this nice research article published in the Journal of Cardiovascular MR in 2017, wherein aortic atheroma has been studied as a source of stroke to assess the embolization risk in stroke patients and controls using 3D CMR technique. So here they've used simple PD weighted, T2 weighted, and T1 weighted sequences, and have tried to study the aortic wall, particularly the aortic arch and descending thoracic aorta. And they have found that the significance of more than 4 mm thick intima and presence of vulnerable plaques in the aortic arch and descending aorta are a relevant etiology of stroke. So this is just an image from this article wherein we see the normal aortic wall. This is an image wherein there is an eccentric thickening here, but it is less than 4 mm. Now, here is an example of a stable plaque. If you see, it is hypointense on all three sequences, PD, T2, and T1, which indicates that it's a calcified plaque. So it's a stable plaque. As against that, if you look at this image, there is a bulge in the wall of aorta. It is bright on PD, on T2 images, and it is heterogeneous on T1 weighted sequence, which indicates that it is probably a complex plaque and has been labeled as AHA grade 6. So based on these MR findings, even the aortic plaques have been classified like the carotid MRI plaques into type 1 to type 8 on the similar grounds as the carotid plaques. Having said this, yes, there is still certain limitation in MRI vessel wall imaging for aorta. It has a limited utility in assessing mobile thrombi unless Cine techniques are used to image the aorta. It overestimates the plaque thickness as compared with transesophageal ultrasound. The technique takes longer scan times and it's less cost effective. But I'm sure in future, with better techniques that are coming up, imaging of aorta would definitely be the way forward. So as we look at future of vessel wall imaging, there are several new techniques that are coming up each day. I would not want to go into the detail of all this, but yes, a special mention to phase sensitive image reconstruction, which has improved the contrast between the lumen of the artery and the wall of the artery. I'll just give you an example of that. So this is a SNAP technique that has come up, which is a PSIR technique, wherein the lumen has become totally black. And now if you look at the wall, and if there is presence of hemorrhage in the wall, it can be very, very easily appreciated. So this is an example of the SNAP technique in cross-section with hemorrhage in the plaque, and this is the lumen. So having said this, I would like to conclude my talk by saying that definitely vessel wall imaging with MRI is the way forward. Eventually, it will be like a one-stop stop for a patient with stroke, wherein the entire stroke protocol would be done to first look at the diffusion-weighted images, to look for acute infarcts, which would be the effect of the plaque, and then to look for the cause of stroke by imaging the vessel wall, and by characterizing, not only characterizing the tissue composition of the plaque, but also by looking at the plaque burden and the presence of acute inflammation of the plaque. Having said this, I would like to thank all of you for your kind attention. Thank you.
Thank you, Dr. Parul. We'll have the discussion towards the end of the session.